individuals. The cost of doing the redetermination itself, because individuals have certain guarantees and rights in terms of protection before they're actually terminated from the program. So you have to give proper notification to the individual. You have to have people, and people have questions. Perhaps the last known address comes back undelivered. You have to be able to, again, try to follow up. So again, I want to be clear, we're not saying we will do the redetermination itself. That itself should be a separate proposal that would be multi-millions, but again, pay for it by individuals. And again, you're removing an individual who is no longer eligible for the program.
So when you say a comprehensive, you really mean a sampling of individuals. When I define comprehensive, it means to me everybody. Obviously, that's not what it means to you.
What we would look at eligibility. Is the department doing Medicaid eligibility versus the individual determination for on each person?
Thank you.
But we would look at benefits, services, administrative costs, and provider claims.
Okay.
Thank you very much. I got it.
We've got Senator Cooper's going to ask the last one. Before he does, Representative Farrar wanted to ask some clarification on this. So as long as you stick on just this audit question, you're recognized.
Thank you. There we go. Is that better? I'll kind of build off the question. When you say audit, are you going to audit the actual governmental agency that puts out these, that service these Medicaid recipients, like DHS, SNAP, and all that? Are you going to do the audit of the department also?
Well, these programs are administered by, Medicaid programs administered by DHS, so our audit would take place in that framework.
So you would do the efficiency of the DHS system also as an audit?
Those systems are being run by DHS, so yes.
If I may, I would add, again, structures matter, chain of command matters as well. So we would look at the organization itself and say, is this org chart reflective of a well-managed, efficiently run system? So I think we would look at the administrative side as well.
Okay. Commissioner Representative Hammer has a clarification and same question, so we're going to stay on the topic of election.
Okay, here's what the way I want to repeat, make sure I'm hearing you right. You got an auditor to go in, and you would take an existing agency, and you would look as whether or not, for example, Medicaid recipients qualify for those services, kind of like a scrubbing type effect. But then you would have the audit that would audit the policy side of it to see if DHS is following the policy to the full effect of what they're supposed to be doing. So it's almost like two different kinds of audits. We're using one word, but is it interchangeable to where you're going to audit the policy side, but then you're going to go in depth and use your own independent resources and perspectives to audit whether or not people qualify to be on Medicaid, whether, and other things along that line. Is that along the lines of where you're going?
I think you're helping this along very well, nicely, thank you. I do want to clarify though, we are not doing an individual redetermination though. That is, as I said, people come back on the program every month, and the anniversary of them coming on was 12 months ago. So in May, did the agency do the redetermination? And those redeterminations do need to be on every single individual. But we can't, that would be a different enterprise in itself, because that's a massive enterprise.
But off the shopping list of the items, you may say you can put this in your shopping cart and change it if you want. You may come back to us and say this is where you're currently auditing procedures. However, we think you can get a better result if you maybe tweak the auditing process, and here are our recommendations. Is that part of the scope of what you're bidding on?
Very, very well described, yes, sir.
Thank you, Mr. Chair.
Okay, we've got a couple other members who have questions on the same subject, so Senator Sanders, is yours on audit?
Yes.
Okay, go ahead, you're right.
And again, I think I'm getting at what Representative Hammer is, and understand too, we have a Bureau of Legislative Audit that does audits. So I think what you were describing was an audit of eligibility. There are other things that you can give you an example. So we had an audit report that came in and audited what we were doing on eligibility for the Our Kids First program. So when a parent was signing up, they would self-report what their income was. The old policy for what we would do at that point was take what they would declare, running it over to Workforce Services, match it up against the data in the WESD file, but that's what you tell what a person is making. And then that would be, we would make an eligibility determination off that. The agency actually removed the requirement for Medicaid to go get the information from the WESD file. They moved that, so they stopped doing that. So we quit doing that type of, so we were simply taking the word of those individuals who were signing up. And it wasn't, I don't know that it was nefarious, maybe a question of time and cost. But so you look at policy, what goes on, and the outcome. Or would you be looking at potential policies that you could put in place? So like a continuous, monthly checking of bank accounts, that sort of thing. That's kind of what you're looking at. Just on eligibility, are there other things within the program that you would take a sampling and an audit or of, other than just eligibility? We focus a lot on eligibility, and I think rightfully so. But are there other things that you would be looking at? Are there other things you'd be looking at?
Definitely, yes. I think an example of that is in long-term care programs, the whole concept of the level of need, which is, becomes very complicated, but it's an issue of what, for a case that's medically complicated, what is the specific level of need that best serves that individual's needs? So there is a whole science to that. There's a methodology of administration, and we can look at those kinds of things as well to determine.
So you wouldn't be going and looking at all those people, but you would be looking at the methodology and the policy in place now?
Correct.
And then potentially what you could go to and derive some impact off of. Is that what we're looking at?
Exactly.
Correct. Thank you.
I know we've really gone over this a lot, but let me try one thing and see if I understand from this discussion. And I'm going to look at a very narrow thing. And the thing is eligibility. We're using the word audit. I'm now learning from this discussion a more appropriate word would be redetermination. Are these people eligible for being on the program? What I'm hearing is what some people like me may think of as a one-time event to check the list and make sure everybody that's on it should be on it, is in actuality something that should already be happening. It should happen on a monthly basis. We have a procedure for doing it. It's called the redetermination procedures. So your audit, with regard to this narrow aspect of the overall comprehensive audit, would consist of saying, here's your procedures for redetermination, here's how you're doing it, and here's a sampling. Your procedure said these people were all eligible. In our sampling, we found that to be true, false, mostly true, mostly false. Therefore, we conclude from this that your current redetermination process is doing a good job of only accepting eligible people, or it's doing a poor job of accepting only eligible people, or it's not being implemented well, or whatever those conclusions might be, so that moving forward, we could help ensure that that redetermination process from month to month is keeping only eligible people on the rolls and preventing ineligible people from being on the rolls in that one narrow arena of your comprehensive audit. And similarly, for other areas of your comprehensive audit, we would learn that type of information and be able to act upon it. Is that a way of talking about that particular thing that feels right?
I think that's very well said, yes.
Okay, and since everyone else has asked an odd question, I'm going to ask one too. And then we're going to go to Senator Cooper for the final question. I just want to, and I know you can't speak to other people who have presented, but this has been a question that has been asked of every group, and we've gotten varying degrees of specificity on what they're going to do. And I guess based on what I'm hearing today, would you tell this group that you would doubt that any of the groups that we are hearing from will conduct a full-fledged redetermination of everybody on the programs, and all of them are basically presenting a proposal that audits the processes and procedures to make sure that we have in place the process? Because I think a lot of us, the reason there's such a high interest is we do not have confidence that's happening right now. Again, I know you're hesitant to speak on other people's proposals, but would you, based on what you've seen in the industry, would you be skeptical that anybody's going to do a full-fledged redetermination?
You can't do it for the amount of money that we're talking about. As I said, redetermination has to be done every month. You've got over 800,000 people on this program. Every month you have, before an individual's anniversary comes up, you have to identify the individual that they've been on the program for 11 months. We are going to redetermine whether you're eligible again, because you're required by federal law to do that redetermination every year. I don't believe the state is doing that redetermination. In fact, I believe the state has asked again for another waiver to not do the redetermination. So the redetermination itself on every individual for the next 12 months, I cannot believe anyone has come to you and said, we can do that on every individual who's on Medicaid for this price.
And let me supplement that by saying that we believe that our proposal is very comprehensive in our commitment to audit the methods and the policies, and we believe that our pricing reflected that. We took an approach that we wanted to invest in those sorts of things because we believe that you're better served by a very high return on that investment, which we believe we can yield for you, instead of lowballing what we bring to the table.
Okay, we're going to move on. Senator Cooper, I think you addressed most of his question at the opening remarks, but he may have a different way of asking that. So Senator Cooper, you're recognized.
Thank you for the presentation. Thank you, Mr. Chair. This has to do with the scope of work and the pieces of those scope and cost having to do with that. This question is, please walk the task force through your cost and work plan so that we can see the work that you plan to do and how much you expect each work element to cost. The goal of this question is for us to understand how you see the scope of this project and the resources you expect to need to deliver on each piece of it.
Thank you. So first off, I would say that we definitely saw this and attempted to clarify in advance that this is a 19-month scope. We saw it as bringing to you a set of findings, but then continuing to be a partner with you in the implementation cycle all the way through the end of the contract phase. So we priced this in a way that did not provide just nominal presence after the 4-month window. Now, generally the way we broke it up is of the $2.2 million that was our price tag, the first 4 months, there's $1 million investment at that phase, which is per month, it's a significantly higher level of intensity of work than it would be for the remaining 15 months. But it leaves enough in the budget for there to be a great level of support. You may do things that require the need for a waiver, for whatever. Now, some of those things are going to involve the agencies implementing these kinds of things, but we want to be there to be your support all the way through that implementation process. I mean, you've got a gentleman here who is the longest-standing National Medicaid Director. I think it's good to have him continue to support you all the way through implementation, and our bid reflected that.
Thank you.
Okay, we've got about 6 on the list here, and I'm sure we'll have more, so we'll start pressing through these. The first one is Surgeon General Bledsoe, you're right.
Hey, thanks so much for coming, and I just wanted to ask a quick question. As the Surgeon General on this task force, I don't have a vote. So my purpose on this task force is to be the eyes and ears and the voice of the governor. And I can tell you one of the things that the governor is very interested in with healthcare reform is actually initiating real reform. We don't want the status quo. We don't want to repackage what we already have. We want to push it as far as we can to get the best plan for the state of Arkansas. Now, I've noticed in your presentation and your RFP that you're already involved in some projects in Arkansas, and that can be taken 2 different ways. One way is that you have a lot of experience in the state, you know the programs, you'll hit the ground running. But the other aspect of that is that there's some concern that maybe you won't be as innovative or you won't have as many fresh ideas because you already have set in your mind the direction that you need to go. So I just want to be very clear here. Do you think that your projects in the state of Arkansas previously, and the current ones that you have, are an asset to you, or do you think that that in any way might shape or confine the recommendations that you might have for the state?
I really appreciate you asking that. I'd like to address that. We definitely see it as an asset. We see, PCG has been very involved in health reform, and what we try to do is to read between the lines that the business line was not necessarily health insurance exchange establishment, that kind of thing, but what it really was states beginning to look at all of these different pieces, public employee benefits, the marketplace that's coming in, the Medicaid program, and what the insurance department does for health insurance, and to really be able to give a comprehensive, hey, it makes sense for these kinds of pieces to fit together. We think that kind of local knowledge of those different components is really key to accomplish a system-wide reform. To the extent that that's a conflict, my attention was drawn to, well, isn't there a bigger conflict if you had a contract with CMS, who you might be negotiating with? To me, that would be more of a concern than a contract with another Arkansas agency that, we work at your direction on all of that kind of stuff. So we see it as an asset, and we believe there's no inconsistencies, and that it provides a greater sense of a broad vision.
Rich, when you say CMS, again, for the slow learner group, could you tell us who CMS is and why you might think that might be a conflict? Because for slow learners like me, maybe we didn't understand what you just said.
Yeah, CMS is the federal agency, the Center for Medicare and Medicaid Services. They govern the Medicaid program, the federal agency, and you're going to be negotiating with them potentially if you decide to move forward with something like 1332 later. So, do you want a vendor that potentially has business on both sides of the fence with that? Is that more of a conflict to consider than a contract with the Arkansas Health Insurance Marketplace, which is a local board that you all control? So I would just raise your attention to, there's lots of ways to look at the issues involved in this.
Can I add to that? When we chose to team with PCG, it was very important to us. We come in from the outside, but we have been following Arkansas for many years. I mean, you have been innovative, you have been pushing into new areas. And we have been following, having dialogue with folks in Arkansas over the years, trying to understand it, report on it, share concepts, look at strengths and weaknesses. When we work inside a state, it takes much, much longer to come in from outside if there are not people who already have boots on the ground and can, in negotiating this team, we are here as thought leadership, new ideas. They are, as Rich says, the engine behind with the technical support. And if we had teamed with someone who didn't know Arkansas, this would not be a 4-month project, it would be much longer. That's partly how we developed this partnership.
Can I ask one other question? Yeah. So one of the things that came out in your testimony today, you talked about some of the super utilizers that drive up costs, and that's been a real concern of mine. The governor has appointed a Medicaid Reform Council and has 30 advisory groups, advocacy groups from around the state who are represented on this council. And the purpose of this council is to give feedback to the task force about how to reform Medicaid and continue to provide services and quality care for the people of Arkansas that retain control over the costs and the growth of spending. The super utilizers are something that's become a focus and interest of mine because I see it as an emergency physician all the time. People come in every 2 to 3 days, sometimes by ambulance, for belly pain or chest pain. When you dig down into the surface, what you realize is that these people have substance abuse problems or behavioral health problems or psychiatric problems, and they're not being managed. They're being managed by a bureaucracy from a distance and not in close context of really helping them as patients, and that's a big problem. I've been looking at the work of a guy named Jeff Brenner out of Camden, New Jersey. I'm not sure if you guys are familiar with him, but we're thinking about bringing him in as a speaker at some point in the future with the Medicaid Reform Council. And my question for you guys is this: could you talk a little bit more about your work with the super utilizer group, how a team approach could help lower the cost for the state and yet give these patients, these people who truly need extra care, give them the care they need?
Yes, sir. And again, acknowledging the problem is always the first step in finding a solution, right? Trying to define what the problem is in these individuals. There are, where you engage individuals and at the emergency room is, as you say, often where they're intervening. So again, you work with the hospital itself and a doctor who is in the emergency room. I treat you, then it's right here and now. I'm obligated, and I will do that. But to change their behavior, especially with somebody with substance abuse, is going to take, that change is going to take over time. But you have to give an individual an alternative to going to that into that emergency room. And that intervention may need to be on a daily basis. So you need to find someone who can do that type of intervention, that understands what is going on with people with mental illness. Medicaid has had a long history of managed care with the moms and kids populations. And if you think that I'm successful with the moms and kids, that will translate over into the different population, is not the case. You have to have people who know how to intervene with these individuals. Substance abuse is the one area to where the literature says giving that individual an incentive does actually work, because it has that incentive, the reward has to be immediate, and it has to be real to that individual. So that's what you're going to need to do. You're going to have to some extent, and Medicaid, this is allowable. We have what is a lockout. Some states call it lock-in, some states call it lockout. But again, to say that you cannot go to any provider, you're going to this doctor and that's it. And those are effective means of engaging people. But it's a very intensive intervention at the very beginning. You truly are changing patterns of behavior that have occurred over months and years. You can't expect it to be. And again, this is something that I think that we want to give realistic alternatives. And again, over a 5-year period of time, if you're even talking about negotiating a waiver, you cannot be thinking, well, I'm going to get this waiver approved in 3 months and I'm going to implement it 3 months later. Waiver negotiations take a hell of a lot longer than that. But I'm sorry, I'm getting a little off track. The intervention with these super utilizers are finding the people who have a relationship with that individual and can build upon it. I'm particularly interested, and I think there's some success out there, home health aides. Some of our lowest paid individuals who have the greatest interaction, who knows what is going on with dentists today, to merge the high touch part of home health with high technology. There's great abuse in the home health industry, as we all know. There's inflated number of hours, etc. Technology can solve a great deal of the fraud part, can solve a great deal of the record keeping because you have to have documentation, etc. But to give a home health aid, I talked about raising expectations of our Medicaid enrollees, raising the expectations of the people who serve Medicaid enrollees. There are home health aides who are, and this is hard work, and it takes a special dedicated person to do that work. There's such high turnover because their work isn't being respected. It's not being rewarded. So part of this is to say, let's give that home health worker a little bit of that coordination care dollar to make certain, again, they know this person better than anybody else. They have the most interaction with them. So it is not a solution that is going to work immediately, everywhere, all at the same time. And the task of coming up with willing providers in rural Northwest Arkansas are going to be different than in Little Rock. I've always talked about finding a willing partner, building a coalition of the willing. You first have to come up with the people who do want to say, yeah, I am willing and able and want to change the way the system works today. Because right now we're rewarded by delivering as much care as possible. If you don't have partners who are willing to change, then you're not going to be successful.
Okay. All right, we've got 6 more, so I'm going to ask members to keep your questions pointed, and you all try to get answers so we get everybody through here, because I know that about lunchtime everybody gets buzzed. So, Senator Irvin, you're right now.
Thank you, and thank you for letting me ask questions. I'm not a member of the task force, but very interested and serve on the advisory council that Dr. Bledsoe is chairing. I thought your point about Medicaid is a finance, we finance, Medicaid finances, does not deliver. So based on, and that the providers are the ones that are delivering the health care, I think that's a fundamental statement that I appreciated. And in thinking that way, sometimes it seems like we do, though, tend, as government, want to fix everything. So we become the deliverers, or we think that we should be becoming the deliverers of the healthcare system. So my question to you is will you, and you also mentioned asthma and different types of, whenever I look at, and from my perspective, there's so many different policies throughout the system that result, a lot of times, that are intended to keep them out of the ER or are intended to save the state money, but really actually in the long run end up spending more money for the state and end up in poor health results for the patient and end up in an emergency room. Asthma is one of them. You talk about different types of switching medications, and there's constant switching of medications. We have fail first policies, and we have all those different things. And for me, looking at just the person, and I'm not here to debate whether those policies work or not. My question is, do you feel like that's part of, I kind of heard you say that that's part of what you were going to do, is try to drill down into the system as a whole and looking at those kinds of policies as well. Is that correct? Do you think that's valuable? And why?
Absolutely valuable. Again, if you are doing something and it's not working, if you are paying a primary care case management fee of $3, $3 very well may not be enough to change that doctor's behavior. If you have a policy to where the child only has one nebulizer and he forgot it at home and has an attack at school, we need to be rethinking to say, well, gee, we need to give him 2 nebulizers. We need to change the rules of the game in many respects. Working with people with chronic healthcare conditions. Again, working with, going back to the child with asthma, example, goes into the emergency room and someone who hasn't really dealt with Dennis doesn't know his history, and they move him from, and think they have to admit it, versus a care coordinator who says, no, Dennis needs this dosage at this time, he will stabilize within 15 minutes, you don't have to admit it as a patient. Those are the things that can work. There are, we talk a lot in healthcare about people with chronic illness. But even there, you need to drill down, and a person with hypertension, there are some people with hypertension who are at greater risk of stroke than others. This is where the data analytics come in. This is where the predictive modeling comes in, of figuring out what is the correct intervention here. And then finding a partner in the community. Maybe a hospital, maybe a primary care doc, maybe a federally qualified health center, maybe a rural health center. Who wants to partner with us to change this behavior, and what will it take to do that? And again, and the other side of that is locking people in and to say, you're going to have to stay with this doctor. You're not going to be able to go everywhere else in the system.
Thank you.
Representative Mix, you're recognized.
Thank you, Mr. Chair. Right here in front of you. My question, first set of questions, is along the lines of what Mr. Bledsoe had done, and that is conflicts of interest. You have, of course, a big contract with the health insurance marketplace here in the state of Arkansas. Are there any other contracts that you may have with the state of Arkansas? Do you believe that there's going to be any conflicts with those? And if so, where would your priority be? Meaning, if the task force goes in the direction of not having a state exchange, which of course would have an impact on the contract that you have, how can we be sure that you will make the task force a priority, and that we can trust the integrity of the data or the integrity of the solutions that you may present to this committee?
On the McKenna side, we have no other contract, so we have no conflict whatsoever.
On the PCG side, in addition to our marketplace contract, we have a contract with the Department of Insurance. We have no active contracts with the Department of Human Services. And I do not see a conflict. We actually have provided a lot of, we worked with states early in the health insurance exchange process and led them up to the point of deciding not to become a state-based marketplace. We did that in Tennessee, we did that in a whole lot of different states. We don't do business by thinking one thing has to be enacted in order for us to progress. The thing that sustains